sharing and talking about in terms of material we can share and go back to, and people have got to. There'll be some slides that I'm going to show, and that's all there for you to pick up later and record anyway.
Chris, did you record last week's catch up?
Yes.
And has that been posted somewhere? I had a hunt around but couldn't find it. If you could send it over as a link on WhatsApp or Teams, that would be fab.
Yeah. So last week. Okay. Yeah, I'll have a look at. Yeah, I'll have a look and see if I can find it.
Right.
It
Thanks.
came through on me. Yeah. Okay. Let me see what I can do, Vicky. Sorry.
That's right. No worries.
Technologies, yeah, it's fun, isn't it? Right. Anyway, right. So, do you want to start, Vicky? Is you there? Do you want to? Where are you? What's happening? Bits that you want to share with us, etc., etc.
Yeah, sure. Where am I? I don't really know whether I'm coming or going. I'm not quite sure where I am. I had a very nice week off last week, so that was lovely, and spent lots of time out in the sun, which was great. It already feels a bit of a distant memory, but hey, it was nice while it lasted. And during that time, I did some work on the second essay, so that was good. I got quite far through that, so I've just got some finishing off to do on that, and then hopefully I can wrap that one up. I'd intended to do some hands-on practicing, and that never really happened. I think we just spent too much time drinking wine on the patio, and that was about it. Going for bike rides. This week I spent a little bit of time looking. What was that? Sorry.
I said on your drinking lots on your patio. Yeah. You might not even have a patio. Anyway, go on. Then listen.
Spent a little bit of time this week having a look through the trail guide, just starting to get to grips, having seen your videos, Chris, on legs. So just started having a look at some of those pages, and also had a look at, from our conversation a couple of weeks ago, had a look at the different, what do they call it, the trails that they do. Did that for the pelvis, the 5 pelvis trails that I had in the book. Yeah, so not really done much hands-on stuff, but I've started looking through the book and getting to grips with some of the muscles and things in the legs and pelvis.
Yeah, good. Okay, that's got to be where we go, and we've done enough around the shoulders now. Really, it's all about, okay, so what's all this lower back stuff about? When people come in with lower back pain, what's the most common? And it's a huge. I know how many people in working life suffer from lower back pain. It's 80%, isn't it? I would think it's a massive amount of people suffer. So, for us to start to unpeel a huge subject, it's going to take a bit of time. But in theory, that's where we've got to go now. We've got to really look at traditional lower back pain. Sorry, Carl, do you say something? Have I got somebody else in the background? No? Okay. Okay, Carl, do you want to give us an update where you are and just things, or have you sort of done that already?
To be honest, I think I've done that already. For me, it's been looking at the documents, and I haven't got hands on at all really the last couple of weeks, being honest with you.
Okay. Okay, that's fine. How about yourself, Joanne?
Yeah.
Any questions you might have? Any thoughts you got? Whatever.
So so I'm kind of nearly finished my 3rd assignment. I was hoping to get it done last weekend, but I kind of it took a little bit longer than I thought. So I've put that to one side. So I've got my A&P exam Friday of next week. So I'm just focusing on that at the moment. Then I'll finish off the other assignment. But my plan is I kind of want to get them out of the way. I've been hands-on a couple of times in the last week. But I've just been focusing on the other stuff. So I think probably what I'll do is, I know you've sent over some new videos. I will have a look at those. I might start to have a bit of a play around with them, but I think my brain is probably at capacity at the moment. So I think I'll probably just continue messing around with the stuff I know. And then after the end of next week, I'll start to kind of pick up a lot of that new stuff. So I'll start to have a look at it, but I probably won't be in any great detail. I would have thought.
And I think the pelvis and lower back pain and structures around hip flexors and extensors is huge. It's a big subject. So I think to do to think, right, I'm going to do that today is too much. I think you're better off just saying, right, what are the main hip flexors? Where are they? Who are they? And just do it really bite-sized pieces. Yeah. So in a month's your A&P revision, 20 minutes learning the hamstrings and where they are and what they do is plenty.
Yeah,
You know what I mean?
Yeah.
Just do that size. It works well that way. It's a big subject. Emma, hi.
Hiya, yeah. I mean, obviously no hands-on with Andy, but I'm sort of itching to get my hands on him again. And I may start that with the legs. I think that might be a safe place to start, perhaps avoiding, the area. Mainly was doing the A&P revision, but I did find that really useful. I worked through the Kate Tierney book, which actually, as it turns out, was a deeper level and made me convinced I was going to fail everything. Then actually, so the paper was a beautiful, pleasant surprise. But it was really useful in that it forced me to look really deeply within the muscles, and so I learned a lot about the hip flexors and extenders and muscles just through doing the A&P revision. So in fact, it proved really useful. So just itching to get hands on again now.
Yeah. Just give us a quick update on Andy. How is he? Is he well and all right?
Yeah, he's absolutely fine. Chest wise, obviously he's still taking the blood thinners until September or whatever, and his ankle is still swollen, but it's kind of going down and then comes up again. So that's just literally an edema. It's literally just water swelling, and I guess whether I can gentle lymph massage, maybe pulling up the water, would be helpful. I'm not sure, but yeah, he's recovered really well.
That's good. I'm pleased to hear that.
Great news,
huge relief for you both. That's great.
Massive, yeah.
Cool. Audrey, good afternoon. Nice to see you.
Okay, it's good to be here, but I have very little to report. I know of the assignment and where I need to get the information and start putting things on paper. I have been before bed getting into some revision, but I haven't actually touched anybody. So it sounds like making excuses, but the house is full, my head is full. Birthdays, people going back to school. I sort of took a step back this week, so hands up. And but I have them lined up. I haven't lost them off the horizon. I just didn't have. It's just one too many things to do this week. So just hands up.
I don't think you need to apologise about any of that. We all go through periods where it all feels a bit overwhelming, and there's other stuff that takes centre stage, and that's the whole the purpose of us doing this on a regular basis is to just keep something going, and if you have a week or two where, do you know what, I can't do anything, I don't think we need to I wouldn't give it a second thought.
I did see your videos. I've downloaded, I followed them. It's something I'm familiar with. Obviously I've done the A&P exam before, it's just I'll have to do it again. And but I will have a discussion with Olivia as to reset a date. It's just not going to be July. It's going to be on the latter part of July.
Yeah, that doesn't. None of that matters. I think you just you got a lot on. So day by day. Okay. I'm going to have a go now. I'm not technical, guys, so you're going to have to stay with me. All right. I'll do my best on this one. I'm going to try and bring on some slides that I want to share. And with a bit of luck, we should get some. These are familiar slides. These are from the day 4 on the level 3 course. Yep, happy with those? See them?
Yeah, great.
Yep. So these are purely from your folder. There's no adjustments to this. All I want to do is just flag up a couple of things and start to talk through.
Sorry, hang on, I'll get my folder.
Yeah. Can you see them all right, Joanne?
No, no, but I'm on my phone, so but I've got my folder in front of me. So if you just let me know which days it's like, have a look through.
So we're on day 4, spine and pelvis. Yeah, can you see? Everybody else see that? Okay, can you?
Yes, yeah.
Vicky, are you okay with that? You can see where I'm on. You can
I can see. Yeah.
Follow this on your on your folders and scribble on accordingly. I just want to start off. I'm on slide. No, they're not numbered, which is not cool. Let's have a look. Oh yeah, slide 4, which is a picture of the back with the erector spinae group. See that okay? Can you see that okay? In terms of the trail guide, I suppose I'm looking at page 189. So trail guide 189, similar kind of slide, and just wanting to just review this rather than talk too much about it. Everybody on the right kind of page? Everybody happy? Can I keep talking?
Yeah.
Yep. Okay. If you lose me or it doesn't make sense or you want me to go over stuff, just shout accordingly. Otherwise, I'm going to continue. Okay. The erector spinae group central there. I think we talked about them quite a lot. The bit that I want to be clear about is the erector spinae, particularly longissimus and iliocostalis. They drop down right down below the PSIs of the lower back. So what slide am I looking at? Yeah, that it's where they drop down. So page on the trail guide, if I go down to page 196, erector spinae group. And you can see longissimus particularly drops down right down almost to the crease of the bottom. And I think it's so important that we understand that lower back pain can radiate up the back. So you can have somebody who presents with hip pain and iliocostalis, you can see on that picture, 196, the picture there, iliocostalis reflected. That comes down around the iliac crest. So people will have pain around the PSIs, lower back pain, QL pain, all that kind of lower stuff. What's important is that we don't necessarily rub where the pain is, that we think about the spinae rubs comes all the way through, and you can see iliocostalis longissimus comes right up to the top of the back and into the neck in cases. So it's a long fascial chain, and I just want to revise that very quickly and say, look, make sure somebody comes in with lower back pain, do not just rub where the pain is. That's the first thing I want to talk about. I'll move on with the slides around terminology of kyphosis and lordosis, scoliosis. I think this is something, again, it's more revision than anything else. This is stuff hopefully you've read about, you understand. And the most common one, I guess, is that lordosis, where the shoulder is thrown forward, a mixture between lordosis and kyphosis, where you've got that kind of rounding, protracted shoulder, and then you've got that lower back kind of pelvis being tilted forward.
Do you have a kyphosis and lordosis issue at the same time?
Yeah, very much so.
You'd have lower back, and then you'd also be, rounded. Yeah.
Very much so, Emma. Sorry, I'm jumping around. I'm pushing the wrong buttons here. Let me go back to that. Sorry. Yes, very much so. They can often go together. You do get just lower back, anterior tilting of the pelvis. And people happy with the idea of anterior tilting of the pelvis? What I mean by that? If I get noddy heads, then I'll run with the idea that we know what we're talking about. Fine. Okay, great. Then often, if you've got that anterior tilting, you will get lordosis, definitely. Kyphosis seems to be often related. It will be wrong to say every time, but in my experience, the two sit together quite often. Obviously, that upper back rounding of the upper shoulders, protraction of the shoulders gives us all the stuff at mid-thoracic pain and bra strap stuff, all that kind of T6 to T7, T8, all that area gets really locked up. The bit I want to bring in very clearly is that people present with mid-thoracic pain. Let's make sure we work on their lower back and vice versa. If people come in with lordosis and lower back pain, let's make sure that we work on mid-thoracic too. That's in terms of our fascial work, really important. On this slide, I just wanted to, oops, sorry, jumping around. My lack of technology, I fiddle around with my mouse and all sorts of things happens, I'm sorry. This slide, traditional kind of picture here, and I just wanted to go through these degenerative conditions. A lot of people talk about this. This is a well-known kind of language. Yeah, herniation or bulging, degenerative, thinning, degenerative in terms of osteoarthritis, degenerative of the lower vertebra. From about the age of, I don't know, mid-50s, then by definition, you know, the condition of the vertebra starts to deteriorate. The discs, by definition, they're 80% water. If our posture and our diet and how we look after ourselves, keeping long, strong muscles, looking after our core stability, you know, not to athletes style, but being able to be reasonably flexible around our lower back. This is where I think probably Pilates and yoga really come into their own. If we eat well and drink well and do the simple exercises of walking and, you know, bit of stretching every day, we can live long and old and not have an issue. Sadly, that's not how life is, and we spend a lot of our time sat on our bums and working and rolling off, you know, louching on our settees because we're exhausted by the end of our working day, and all this degenerative stuff starts to occur. Let's be clear that when some of the terminology that is thrown around, I remember early on in my career, you know, clients coming to me saying, well, I've been to see my osteopath or my chiropractor and he put my back back in, or he put my pelvis back. And these are phrases and terms that aren't actually accurate. If you actually slip a disc and there's a movement of anything of any one direction, you'd probably be fairly paralyzed. So they're phrases that are used to I don't know, I mean, create some level of anxiety, I think, in clients. Discs don't slip, they bulge and they herniate and they spread on, like the pictures there on herniated disc. The disc will push onto a nerve and cause referred pain and cause the muscles around here to really tighten up and spasm to protect the swollen area. And you get that place where people bend over sideways and can't straighten up because there's some, you know, the discs of protecting themselves and all the muscles around there go into sort of lockdown. Yeah, that's a good phrase. I like that.
Have I heard that before?
Yeah, that's a familiar little phrase, isn't it? So do some reading around this. Think about this. Bulging probably after the age of 55 and 60 onwards. Most of us have got bulging of our discs in one form or other. It's all a question of length and strength and keeping a reasonable posture and looking after ourselves. Does anybody want to chip in with any stories or bits that you bring, or any questions around that, or bits that you want to add or, you know, share?
No, just curious as to where the idea of this, the concept of slipped disc came in, when it evidently isn't about discs slipping, it's bulging or herniating. Just quite curious, really, as to where that kind of came into the common parlance of.
Yeah. I don't know. I mean, it's a good question, Emma, and I don't. Other than, yeah, I think it's appropriate that we are respectful of other professions. Of course, it is. But also I do know that particularly the chiropractic kind of model is that we like to see you lots of times. So you will have a chiropractor who will say to you, look, I want to see you twice a week for the next 4 weeks, and then we'll review where we are. Where the osteopathic view tends to be, look, let's do a couple of treatments here, then we'll review where we are, and if it feels right, then maybe I'll see you in 3 weeks. Or, you know, osteopathic view is quite kind of driven into self-management, getting your client to be self-managing, where the chiropractic tends to be slightly more kind of let's do little and often. And I know that just different schools of thinking, I think, and approach to the work.
And Chris, if you allow me to interrupt, but this is Audrey. Yeah, I believe in healing from within, and I also believe that generally speaking, people are ill-informed. So to a degree is down to us to explain to people what it is. So when you hear things like that, I don't hesitate to sort of go back and help people understand what the problem is. I'm not saying that I'm diagnosing, but when we talk about it and then explain what those differences are. So understanding where the bulging is, what the thinning is, and like Chris just explained, it's not necessarily the bone itself, but is the one in between, the shock absorber, yeah. So the in between the vertebrae, and explain what that's when it bulges and is pushing into the nerve and the pain and everything else. So I think that helps clear a little bit of what people misunderstand about it. And then to that effect, when he said about the yoga and the Pilates, that is exactly it. So it is in your own power to do something about it. And I find that some people have that self-belief in that I can do it, but other people like to be led into that.
Sure.
And then you have two things. If you can afford the chiropractor who says you have to be here for an indefinite amount of time, then by all means, then, and it's almost like you give it away, he will fix me. Whereas I believe that is a model. I'm not saying you can't adopt that model, but it is quite expensive. And there is something that you can do about it. And you haven't arrived at that situation overnight. Equally, you don't come out of it overnight. But the little and often go a long way. And you become a little bit more self-aware when things aren't, as if your body starts talking to you, in that you notice a little bit more. And that wasn't there on day one. And slowly you notice it. And it's also this idea that, oh, my knee is wrong. But no, it's about you. So it's not the knee, it's not the arm. You are not feeling 100%. And it's part of that, the self-awareness that happens. But there are two minds about it. Do I take responsibility for, if you like, even if you go to a physiotherapist and he gives you loads of exercises or all the things that we don't necessarily always embrace that and incorporate in your daily life. And it's that gap into finding the motivation or enough to continue at it, to then start feeling the change, because all of a sudden, oh, you forget about it. Yeah, when it no longer bothers you, you forget about it. And we just need to remind us, are you still feeling that? No, not anymore. But people don't necessarily come to you when they are happy. They come to you when they are unhappy about something. So that is my little 2 cents.
Let me just transfer this into a treatment setting. So just get it into a treatment. So somebody comes and sees you, they suffer from lower back. It's always been a bit, now and again. 2 years ago, they had an episode where it spasmed up and they weren't really sure what was going on. Last weekend, they were mucking around in their garden, they were digging, it was a hot day, blah, 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 blah. Their back spasmed and they pulled over to one side and, they're kinked on one side. They can't really straighten up. They think it's a great idea that a bit of massage, all it needs is easing out and softening. So with that picture, we need to tread really carefully. Muscle spasm to protect a localized area. So whether or not it's a bit of bulging, possibly, whether or not it's just a bit of muscle that's been overused because their core's poor and they just got into sort of lifting too much or shifting themselves around too much or too much digging too quickly, all that kind of stuff. We have to tread very carefully, and that kind of 5 to 10 days post an event, an acute injury, we don't go in. We just let things go on and let things kind of, pain management, if they want to do that, advise them to go to their pharmacists and look after themselves and drink lots of water and blah, blah, blah. All right, so I just want to be clear here that these kinds of bulging and bits of degeneration is very much our business, but only when there's not an acute injury involved or an acute inflammation involved. Does that make sense? I just wanted to just bring that in so we're clear that lower back stuff is that chronic stuff that we're good at, and when the inflammation's calmed down, then we move into a place where we start measuring, why is this happening? Why is this lower back stuff happening? And we could spend the rest of the flipping day talking about lower back and all the different kind of variations of problems. But that general approach to people, I think, is really good. And if you don't know, then refer them back into their GPs or physiotherapists. I like physio. I'm a real pro physios, mainly because they can communicate very well with the GP if they need to. They're all under the same kind of umbrella. And I like that model. But you pick whichever one you want to. And often clients will have their own, oh yeah, I go and see Mary. She's a McTimoney chiropractor. I really like her. She sorted me out for the last 5 years. Brilliant. Go back and see Mary. That's good. You might work with Mary. You might say, Mary, I've been, working with your client, doing a bit of soft tissue work. Let's work together. Lovely idea. Really nice idea.
Do physiotherapists touch acute injury, or do they have a similar protocol?
They would have a similar protocol in terms of an acuteness. I think they might do more neurological release work to an extent. Emma, I don't know. I'm just really cautious because if we go in too early, then we just aggravate the irritation, don't we? And because our stuff is muscle and tissue work, if that is, if you pulled your QL and you pulled over to one side and it's really sore, having somebody dig their fist in or their elbow in, however gently, actually just rips the plaster off too early. Yeah. Does that make sense?
Still in its healing. Yeah, it's still in its healing stage.
And I use that analogy with the client. Just imagine you giving yourself a nasty cut while cutting your vegetables. You stick a plaster on it. 24 hours later, you wouldn't just rip the plaster off and just pretend it's all okay, because it takes a week, doesn't it, for a nasty cut to get better. And after a week, fine, let's start working on the scar tissue. Let's get those muscles working back together again. Brilliant. We're good at that. And when in doubt, wait, is my general theme. When in doubt, wait. Anyway, I wanted to go through that, just to explain a little bit about degeneration. Have a think about it. If you have any questions more about that, yeah, that's all I want to say. Let's go on. The next two slides, upper cross syndrome and lower cross syndrome, I wanted to bring in just so it's a new language. Lower cross syndrome is where you can see tight iliopsoas, tight erector spinae, QL muscles, weak abdominals and weak glutes, which is our classic anterior tilting of the pelvis. Our hip flexors are pulling the front of the pelvis down, and our erector spinae group and QL are pulling up the back of the pelvis. Weak abdominal muscles are not stabilizing, and the glutes are not firing to work with the hip flexors. And so you have this rotation anteriorly of the pelvis, giving us that lordosis. Not always, but it's often somewhere in there. And upper cross syndrome, osteopaths use this terminology a lot. So you might well get a referral where somebody says, look, I've got somebody with lower cross syndrome. You say, what? I've never heard of it. Well, I just want to pop them in because they're quite nice phrases that are used. And do a bit of research around them if you want. They're really useful. Okay, I'm going to jump a few and talk about sciatica. I didn't do the video on the separating out piriformis syndrome and sciatica because I wanted to just talk through this a little bit before I do that video. Really common sciatica. It's a generic term. I find people will say I've got sciatic pain generating down the leg. It can go down to the back of the foot. It can go onto the big toe. It can go down the front. It can go everywhere. Sciatica in its true form, you can see from that slide, that bulging of the disc that pushes onto the nerve, referring that pain down the leg and through down to the back of the leg. Yeah, can happen by just overuse, and is often related to a postural. Drivers, taxi drivers sometimes get this. People that carry heavy weights. Yeah, I think fairly straightforward.
Does pinching of the nerve ever happen unrelated to the vertebrae?
Yes. If you have somebody who has not got lower back pain, so their lumbar version, the sciatic nerve goes into L4 to S1. I'm pretty sure it's L4 to S1, or it's L5 to S3. It has 4 different ways in which it goes into the vertebra, and certainly part of the sacrum as well. Check it. I don't want to mess around, but it's down very low. And depending, we cover this a bit more in detail in level 4, but today for us, I think it's just important to identify that if you have sciatica, you have lower back pain, spasm in the lower back quite often, and also that radiates down the leg. If you don't have pain in the lower back, I don't have anything in my lower back at all. This is all, and I think welcome to Joanne. If you've got pain in your bottom and it's just in your bottom and it's down the leg, then that's piriformis syndrome.
Okay.
So there's 2 very clear, distinct things, and it is clear. It is clear. You will get one or the other. You won't get piriformis syndrome that gives you lower back pain. You can get that as the pain of sciatica reduces and your spasm in your lower back reduces and it gets better. Yet the lower back pain is not so much there, but I'm still left with this glute pain. Yes, that happens. But my experience is that piriformis syndrome and QL work go together, not sciatica. So people think they've got sciatica, i.e. pinching of the nerve in the lower vertebra. But in fact, what they've got is the longissimus iliocostalis, those long erector spinae groups, and the QL muscle, quadratus lumborum, all go into tightness because of lack of core stability, giving you pain in the lower back. But as well as that, you've got piriformis syndrome, where you've got the piriformis, that piriformis muscle that comes across the glute, and that gets pinched and restricted by the nerve. So you can get piriformis and lower back pain together. Does that help, Emma? Does that?
Yes, it does. Yeah.
And I will do a video on piriformis syndrome and identifying sciatica.
Okay, great.
I said I was going to do it, but I wanted to just talk a bit more about it rather than just do the video. Any thoughts about that? Happy with that? Pretty.
Yeah.
Sure. So these next few slides are really just confirming what we've already talked about. Slide 14, you can see that anterior posterior rotation of the pelvis. And the key bit here is remembering that you get that lifting of the pelvis as well. So you get that lateral tilt. These are little slides from the trail guide. And this often comes, lateral tilt comes, and you can see what muscle group would cause the iliums to lift in that way. What do you think?
The glutes, possibly.
So the glutes are going to be on the pelvis, I think, aren't they? Yeah, they're going to be on the back of the on that picture on the right hand side there. You got back of the glutes will be there. They will come across, join on to the femur, wouldn't they? Because their femur extension and adduction of the femur. So, but I'm just thinking of that, where that arrow is lifting that pelvis laterally.
Oh, sorry, I was looking at the posterior tilt.
Yeah, yeah, okay.
QL.
Yeah,
Oh, the QLs, yeah.
yeah,
QL.
absolutely, absolutely. So you get that imbalance. QL is going to lift your pelvis along with the erector spinae. So you get somebody who's very dominated. The first time I came across this was somebody who's a gardener, and they just did a lot of raking and hoeing on one side. So they were constantly kind of dominantly leaning over one way all the time. And therefore you had this real kind of lifting and rotation of the pelvis. And this is what was presented every time. So
You should call it handbag syndrome, because I think you tend to do that with carrying a bag the whole time.
yeah, true. Very similar. Very similar. I'm going to jump some of these because this will give you stuff to read and digest. Main muscle groups here goes without saying. We've got to separate and get clear with our groups of muscles here. Let's just be clear about the difference between the extensors and the flexors of the pelvis. Is it useful for me just to present this? Is it, or, you know, I'm aware that you're sitting there in silence. Is it better that I just go through it at this stage?
It's all
Yeah.
Okay. I just don't want you to think, oh my God, for Christ's sake, Chris, shut up. You know, if you do that, then just point a finger at me or something, or whatever. Okay, so let's be clear. What I want you to do is learn 4 main hip flexors. And the 4 main hip flexors, technically they're 5, but let's put them together as 4. The iliopsoas, ilium, iliacus, and the psoas put together as the iliopsoas group. So you've got 2 muscles. You need to know where that is and its origins, assertions, and actions. Be clear. The next one, so I'm going to present these in line of strength, which is so important. Iliopsoas, biggest one, sort of half the diameter of your wrist. So they're strong muscles. They're meaty. The next one is the tensor fasciculata muscle, TFL, in the hip. Joins on just underneath by the iliac crest, and then feeds into the IT band. It's a strong hip flexor. Hip flexor. It's our 3rd strongest hip flexor. Again, you've got to know where to find it. The trail guide's all there. It'll show you how to find it. I think I did a video and Judith didn't know where I sort of identified it. I've done a couple of those. So you need to be able to find that muscle, how to palpate it. The 4th one is sartorius. That's the 3rd in my model of iliopsoas being together, TFL, and then sartorius, 3rd longest hip flexor. Joins through onto the pars antorinus down on the medial aspect below the knee, comes up and actually joins on to the anterior superior iliac spine, ASIS. So it's there. That's where it joins onto the pelvis, ASIS. Comes down across the leg and then swoops down onto the medial aspect of the knee, just onto the pars antorinus. Be helpful for you to do when you're doing the hip flexors and the hamstrings. It's really quite helpful to do the bony landmarks of the knee in the trail guide. Can't remember what page that is, but you know, it's a short 2 or 3 simple bony landmarks of the knee, but it shows us the pars antorinus. It shows us the condyles and where they are. So when it comes to thinking about hamstrings and hip flexors, we can see immediately where these all come in and attach below the knee, which is helpful. Pars antorinus is Latin for goose's foot. So the bit of shape of the bone below the knee is shaped like a goose's foot, apparently. And the 4th one is rectus femoris, very obvious one, rec fem. Be clear that the rec fem attaches onto the AIIS, so that's just below the anterior superior. So it's the anterior inferior iliac spine, which is just below that lump on our most anterior aspect of our pelvis. comes down the center. So if you put your finger on that little tuberance and put your other finger on somebody's kneecap, draw a line between the two, that's rec fem. And rec fem, as we know, is the only one of our quadriceps that is a hip flexor and a knee extender too. So it flexes the hip and extends the knee. The other quadriceps don't do that, they just flex knee. Sorry, extend knee. So there are 4 hip flexors. Okay, so iliopsoas, tensor fasciolatus, sartorius, rec fem. We've got to know them, we've got to know where they are, start drawing them on people or yourself if you fancy doing that kind of thing. That'll be quite fun. I'll leave that with you to self-explore.
I keep telling my children off for drawing on themselves because it takes forever to clean them. It looks like they haven't had a shower and now you're asking me for that. Yeah.
Judith's still wandering around with drawing on her bottoms. She's been like it for about 3 weeks now. So so that's our hip flexors. Now let's look at our hip extensors. So these are a group of muscles that take our knee out behind us. By far the strongest is our glute maximus. Glute max is our main hip extender. Glute maximus does not join onto the greater trochanter, where the other glutes do. The glute maximus doesn't. And then the other three extensors are the hamstrings. And they're the 4, they're the groups that I use. So in terms of hamstrings, obviously you've got bicep femoris, which is our outside one, goes down, just joins onto the ischial tuberosity. I drew that on the video yesterday. I think it was the second one I sent. When I was massaging the hamstrings, I just put a little pencil mark around on the ischial tuberosity on Judith's glutes, just to be able to show you where that is. It's again, the child guide's great for that. The videos, if you do the videos of the hamstrings, he shows it really lovely, really simple, nice, easy, bony landmark to find. Bicep femoris comes down and joins onto the lateral outside of the leg of the head of the femur. Sorry, the fibula on the outside. So it joins down on that shaft of the lower leg, and that smaller bone of the tib and fib joins onto the top of the fibula. And then the 2 other hamstrings, semimembranosus and semitendinosus, both medial. And I'm just writing as I go.
Sorry.
Go on.
Can I ask a question? Yeah, are the semimembranosus, can't even say it, and semitendinosus, so they made, I'm just looking at their names, are they made of slightly different muscle tissue? Are they slightly more tendinous or fibrous than, say, for instance, the bicep femoris?
No, actually, the bicep femoris is the biggest.
Yeah.
Out of the 3. I think the semimembranosus is slightly bigger than semitendinosus. Semitendinosus sits on top of the membranosus, sits underneath. They both come round onto the inside. One comes down, tendinosus comes down to the pars antorinus, and the membranosus comes onto the condyle, the edge of the shaft of the tibula on the inside. Just to explain a bit more what you were thinking about. Are you thinking that
if they were, because they're very sort of tight muscle, and I was wondering if there were more tendinous, if you like, more, it's made of sort of more fibrous tissue rather than that sort of spongy, soft muscle.
Don't know. Good question.
Okay.
I don't know. Usually, in terms of fascial linking, generally speaking, and this is a bit of a general statement, and you'll be able to tear it apart quite regularly in your treatments, but as a theme, in terms of lower back pain, if you've got somebody who hasn't got an anterior tilt to the pelvis, but they do have lower back pain, if they have tight hamstrings, it is often related to the bicep femoris.
Okay.
So bicep femoris often presents itself out of the 3 hamstrings as being the tightest.
Okay.
So you have people who you know, very common lower back pain, and the ligament that runs through the spine through the lower back is related to that, and we'll talk more about that as we go. Let me just. How's that all going? I'm aware of. I don't want to overload people. I want to have a look at page 284 on the trail guide. You happy with that? Bony landmarks of the pelvis, the trail. I know we talked about it a bit before. I want you, if you can, start practicing that. I think it's a nice way. I've done a little bit with it with the videos I've made with Judith. I found out the kind of, you know, the PSIs and the coccyx and got that kind of triangle. We've talked about, haven't we, when we massaged the glutes coming in to the edge of the sacrum. I think hopefully that should feel reasonably okay, comfortable enough. The bits I want to make sure about is trail number 4, the hip hike, and just make sure that we're happy with the iliac crest, greater trochanter, and the gluteal tuberosity. The gluteal tuberosity is where glute maximus attaches. So when we massage the hamstrings, we come up the back of, you know, the person's laying on their tummy, obviously, and we're coming up the back of their leg. If we have our hand coming up fairly lateral, we can feel quite hard toughness around the curve of their glutes. And we think, gosh, you're tight hamstrings. Well, actually, what we're touching is the glute maximus attachment on the back of the femur. Does that make sense? Nod, shake.
Yeah, I was having trouble picturing that then.
Okay, let me run through it again. So you've got somebody laying on their tummy.
Yeah.
You're massaging their back of their leg from the knee upwards. You've got the ischial tuberosity, which would be, just imagine that, let's just imagine they've got their, obviously got their underwear on, draw a line between their inner thigh and their outer leg, you know, so that you've got pans both sides of their leg. In about the middle, on the crease of the bottom, you've got the ischial tuberosity. Pretty much, it kind of sits in the middle. Obviously, different sizes of legs and all sorts of it, but roughly the ischial tuberosity is kind of in the middle, just off onto the glute tissue. Yeah.
Yeah, I know. Yeah, okay, I've got it now.
Can you picture that? And
Yeah.
what I'm looking for on trail number 4 is C, which is the gluteal tuberosity, which actually is more lateral. In other words, it's more on the outside. And as you come up the massage of the hamstring, rather than coming up the center, you come out, so you're touching up the side of the leg on the outside edge. And you often will find that you hit a bit that you think, oh, blimey, that's a really tight. And sometimes we get confused about that being a hamstring, and it's not. It's the glute maximus attachment, strong attachment on the back of the femur that gives it our ability to lift our knee off the ground in this particular position, because you're laying flat. To lift your knee off the ground, you're going to lose glute max to do that, and your hamstrings. And glute max, that's where it attaches. So I just want to sort of pinpoint some of those areas. Those bony landmarks are really important. Have a go if you can about sort of identifying those. The coccyx, I think, is pretty easy to find. The PSIs, we've done all that. Side of the sacrum, happy with that. You've done the walls and sides of the sacrum in terms of glute max. That's all fairly obvious. I just want to be clear about finding greater trochanter and the gluteal tuberosity. Just 2 important bony landmarks that are really essential to working on piriformis and also the glute max particularly. The rest of the trials around that, I I think we're pretty well covered, really. I feel fairly.
Chris, forgive me, Chris. So you want a film on finding the bony landmarks and palpating the muscles, leg muscles?
Yeah, it leads me then into. I think that sort of completes where I want to go for today. I just want to go a little bit of detail around the spine, and now let's think about what's useful in us all over the next, fortnight or whatever time we need to sort of now make things happen. Let's get some videos together. What's helpful to get together? What's helpful for you? What do you feel is manageable? What do I want to see? I want to see some massage of legs. You've got a couple of videos now of me doing them, front and back. So it'll be good to see some of that. It will be great to see some bony landmarks being drawn on. What I've just talked about in terms of gluteal tuberosity and ischial tuberosity, bony landmarks. Maybe do some bony landmarks of the knee and find some of these attachments, pars anzerinus, fibula. I'm happy to do a video of that if that's helpful. Or talk to me. What's helpful now?
Have we got any massage of the front of the leg? I've seen the back of the leg, of the top and lower back leg. Have we got any of the front?
Yeah, no. There is one on the blog page, but
oh, is there? Okay.
But I'll do one. I'll do one, Emma. That bit.
That's okay.
Let me do one, and then I can tune it into what we've been talking about. I think that would be better. Yeah, good idea. I'll do that. I'll do the piriformis syndrome testing, and then front or hips. Just talking through what we've just done. How does that all feel? Joanne, talk to me.
I'm okay.
Does that
Good.
does it feel manageable? I don't want to put you in a place where you're trying to do too much, or you feel a bit flipping out. You've got no idea what's going on in my life, Chris. I want to make sure that you feel kind of, it's bite-sized pieces.
I'm okay, Chris.
Yeah. Okay.
Yeah, it's quite nice to to kind of be new stuff to look at. So yeah, it's quite good.
Yeah. Okay.
Yeah, I'll try to get my best to get a look in as well, Chris.
Carl, you're in a forgive me, but you're in a crazy place. So make sure you don't. You've got your.
No. But if I do get the opportunity, I will. That's what I'm saying. Yeah. So yeah.
If it works and you get a bit done, that would be great to see some of your work. But can completely get it. Blimey, you're about to pack up your whole family. So don't worry, whatever's manageable. Let's go with that. And I'm aware of time. We run over a bit, but there we are. We're good for time. Yeah, I'm happy with that. Any questions, or does it feel? I decided to get a bit more structured today, but
yeah, it's good.
Yeah, it's good. Yeah.
Yeah, worked well.
Yeah, that was good. Yeah.
So what are we going to do? We've got to know our hip flexors, we've got to know our hip extensors, we've got to know where they all join, and we've got to know the bony landmarks around the pelvis and the knee. That's it, isn't it? And if we try and get all that together, video me little bits if you want to, share little bits and pieces, and we'll come back next week and we'll kind of carry on maybe the same discussion again, or just keep adding to it. Or so hip flexors, hip extensors, bony landmarks, and then videos of massage. If you want to send some pictures of, I've drawn on somebody's leg, here's a rec fem, here's sartorius, here's TFL, iliopsoas, you can't really, you draw that. It's interesting, it joins pretty well where our navel is, on our navel, back onto our spine. It will be in the classroom when I show you about iliopsoas. I don't think I talked about that, did I, in the classroom, iliopsoas release. I won't try and do. I'm not going to try and do that without. It'll be good to have hands-on with you, with our gloves and our space suits and helmets.
Hazmat suits.
visors, and I'm going to buy some of the gloves that come all the way up to my armpit. Sorry, it's not really appropriate, is it, to be funny?
No, it's just sad, isn't it? It's just really sad.
Yeah, it is. It is sad. I think, one of the saddest things for me is how the whole thing has been reported and the amount of anxiety and fear. If I had young children, and I know you have, going back to school and being told how frightening it is to play with their mates.
Yeah, I think it's really psychologically damaging. I think, especially for the younger ones.
Yeah, make me very upset. You can't go and play with your mate because actually you might die.
Yeah,
and
or being told no, you can't touch, you can't do this, you can't. Yeah, it's really.
I think they're utterly devastating myself. But anyway, there you go. And it's just not true either. That's the other bit. Anyway, I will. I've been recording on this, so I've just told you now that it's just not true. My tutor told me that it's fine. So there you go. I've got him on recording. Anyway. All right. Any bits that anybody wants to bring in? Should we call it a pause there? Are you okay, Vicky? Are you all right?
Yeah, all good. Yeah, good. Thanks.
All right. Does that make sense? If you have any bits you want to share, or you're not sure, or you look at this again, you think great, then just come back to me, and I'm around. Nice to see all your friends.
Yeah,
Thanks, Chris.
Thank you, Chris. Thank you. Bye, everybody.
Yeah, thanks, Chris.
Bye, everyone.
Thanks. Bye-bye.
Next week.
Cheers.
Go.
Bye.
Bye.